Great, thanks Cliff. Good afternoon folks, and thanks for coming. So hopefully this will be interesting to some extent for you. You've all done this lots of times before. You've all managed many cardiac arrests. You're all familiar with most of the evidence. Some of the stuff might be new, some of the toys might be new, but this is just to re-emphasize the important parts. So what do we do that makes a difference, and what do we do that probably doesn't make a difference? One of the first things I'd like to say is that what we're talking about here is medical cardiac arrest. This is not a traumatic cardiac arrest, as Carl spoke about earlier on in the M&M. They're two completely different animals. Okay, the way you manage a traumatic cardiac arrest is entirely different to the way you manage a medical cardiac arrest because of the precipitating cause. So is it a big problem here in Sydney? Who's managed a cardiac arrest in the last 24 hours? In the last week? In the last month? In the last year? Okay, so everybody here has done it at some point in the recent past. Do we know how much of a problem it is? Well, in 2006 we knew how much of a problem it was. There were about 2,000 cardiac arrests in 2006 in the Sydney basin, and the survival is kind of variable. And we'll talk a bit more about how you record survival rates in a minute, but if you look at the second line from bottom, 11.5% survived to 1 year. Now, what does that really mean? Does that mean they were alive, or does that mean they went back to work and had a normal functioning life? There was no data recorded in this paper on the functional outcome. That's the really important thing, because what do we want to have as the outcome from a cardiac arrest? Do you want somebody who goes back to their family, or do you want somebody who goes to ICU and fades away over 28 days? Yeah, you ticked a box, you got ROSC, you got survival hospital admission, your system looks like it's doing a great job, but is it really? So survival with functional outcome is the really important thing. Some places do this quite well, and we've heard a bit about Hennepin County earlier on today. Hennepin County is, as you know, in the US, and there are some other places in the US. So King County in Washington has a really good survival from out-of-hospital cardiac arrest. Hennepin County claims they've got a 49.4% survival from cardiac arrest. Now, if you compare that with 11 point something percent that we have in Sydney, there's a big difference there. How much of that is real difference, and how much of that is difference because of the way the evidence is recorded? So we've got to have an absolutely standard way of recording the evidence. Anybody know what that is?
Osteen style.
Osteen. Guess what the next slide's going to be? It's Osteen Abbey, because a whole gang of people got together in Osteen Abbey, had a few bottles of wine, and came up with the Osteen way of, this is a true story, the Osteen way of recording cardiac arrest outcome and cardiac arrest data. So if you're not following the Osteen template, then the data that you record probably isn't going to be accurate enough to compare to other systems. So that's really, really important. And again, I'll emphasize that getting ROSC is not a really good outcome measure. It looks great, you think you've done a great job, but the real outcome measure is that patient alive at 1 month, at 1 year, and have they gone back to their normal functioning life? How do we know if that's happened? Well, a cardiac arrest registry is the best way to do this. And there are lots of cardiac arrest registries around the world, particularly in the US, quite a few in Europe, and there's a really good and well-developed one in Victoria. So the Victorian Ambulance Cardiac Arrest Registry has a huge amount of data recorded. They record this every year. They publish lots and lots of papers. So in the 2011-12 year, I think they published 14 papers, 9 of them were in resuscitation, so a really high-end journal. If you don't collect the data, if you don't analyse it, you don't know what you're doing. You don't know where you're getting better, worse, are you doing more work, less work? So the cardiac arrest registry also helps in your service planning. Do I need to have more ambulances here, less here as the population changes, and so on. The other thing about cardiac arrest registries is that if they record with the Osteen template, you can pool the data. So if you're trying to get, if you're looking for small changes in patient outcome, you need large numbers to prove that to significant effects. So if you can pool the data, if it's all recorded in the same fashion, you can get higher powered results. Is there much research in cardiac arrest? If you check for it, you get 50,500 papers. So for the next 2 hours, we're going to go through each of those individually. Okay, let's not. But the key thing to remember is that there is a huge amount of evidence out there, but you've got to look for the quality of the evidence. So some of the papers are done in mannequins, which is absolutely valid, but how does that translate to clinical practice? We're not entirely sure. Some of the papers are done on small numbers of patients. How does that translate to bigger populations? We don't know. Randomized controlled trials are what we need, but it's very difficult to do good quality randomized controlled trials, as we know, in the pre-hospital environment. So you've got to take the best of what you have and try and put it all together and get the answer, because that's what we're all looking for. We don't really care about an experimental paper on pigs, not really. What we want is, what do I do when I go to my next 56-year-old guy in cardiac arrest? What is the best thing for me to do to get the best possible outcome for that patient? And there are some predictors of out of hospital or survival from out of hospital cardiac arrest. You can probably guess what those are. You've heard them all before. So rapid activation of VMS is vital. Immediate CPR is vital. As soon as your heart stops, your brain isn't getting perfused, so your functional outcome from that point starts to deteriorate. You need to get early defibrillation. You want to fix the cause. We talk about the H's and T's, we talk about fixing the cause, but the real cause of your cardiac arrest is the VF. So you need to reverse that with early defibrillation. And if you get VF as a presenting rhythm, that is kind of fixable. So that's a predictor of good outcome from cardiac arrest. What do those points all transfer into? What have you seen before? You've seen the chain of survival. You've heard of this hundreds of times in the past, and it still holds true. It's absolutely vital. So early access is your dispatch centre recognising that this is a cardiac arrest and mobilising the correct response. It's about getting your bystanders to do CPR. Even if it's not CPR as good as we would like to think we do, at least as providers, at least get some sort of good quality CPR going before we get there. Early defibrillation, so making sure that your dispatch centres know where the AEDs are, make sure that the dispatch centre will advise people how to do CPR if they're willing to do it, and advise people of where the closest AED is, and make somebody go and get it and use it before the ambulance actually gets there. Early ACLS, does it really matter? We'd like to think it does, but we'll have a look at that in more detail later on. And early post-resuscitative care is probably an area that's developing that Helen's going to talk about a little bit in the afternoon. So, let's see if this works. How do you get people to do CPR before you get there? If it's a randomer in the street,
Get an actor
get an actor.
and a catchy tune.
My name is Vinnie Jones, and I'm going to teach you a lesson you'll never forget. There are times in life when being tough comes in handy. Say some geezer collapses in front of you. What do? We need a volunteer that ain't breathing. It's one I made earlier.
Cliff, this is where you come in.
First thing you do is you check him over. If he ain't responsive or he ain't breathing, or he's making noises like this, then his heart will stop working, he's having a cardiac arrest. Look lively. First call 999, then you do hands-only CPR, and no kissing. You only kiss your missus on the lips. Watch, lock your fingers together, knuckles up, then push down, right on the sovereign. Push down 5 or 6 centimetres. That's about 2 inches in old money. Push hard and fast, about 2 times a second, like to the beat of staying alive. Worried you're alerting? Better a cracked rib than in kicking the bucket. Keep this up till the ambulance arrives. So don't forget, check him over. Call 999, push hard and fast and staying alive. It works. Hands-only CPR. It ain't as hard as it looks. If you want to come in handy in an emergency, why not sign up for one of our heart staff courses?
What's the average response time for a Sydney ambulance? Do we know? 11 minutes. So if nobody does CPR from the time this guy arrests while the call is going through the dispatch centre and the ambulance is getting mobile and arriving on scene and getting out and getting the kit out and getting to the patient, getting the kit opened and started, the substrate's not really going to be much to work with, is it? So you can probably get a huge survival benefit from making, or not making, you can't force them, but by encouraging bystanders to do CPR. So stuff like this actually works and probably makes a bigger benefit to the whole public health outcome than a lot of the advanced stuff that we like to play with. So what happens afterwards when we do get there? Well, you're all very familiar with the ALS algorithms, and if you look at these from anywhere around the world, they're pretty much the same. So they involve opening the airway, getting some sort of airway device in at some point in time, getting chest compressions ongoing, getting some sort of vascular access, giving some sort of drugs to make us feel better, and ideally defibrillating the patient if they're in a shock of a rhythm, and getting the patient to the hospital at some point in time. Does that make sense? Yeah, I'm not going to go through it in detail because it's all the same stuff. But the important thing that has been re-emphasised with the new guidelines is that it's instead of being ABC as it has been since time began, it's now CAB. So the compressions or the circulation aspect are the important thing. And the important thing about them is that it's got to be 5 centimeters depth. Okay, so all of the guidelines say 5 centimeters, and you need to get that 5 centimeters. So if you don't compress enough, you're not compressing the heart, you're not getting blood out, so you've got to get that 5 centimeter depth. You've got to have full release. If you don't fully release and allow the chest to recoil, you don't get blood being sucked back in, therefore the next compression is not going to be as effective. You can charge with the defibrillator on, you can charge the defibrillator while you've got hands on the chest. Only in America could you convince medical students to be shocked. And they've done that, okay? So they've got medical students to do chest compressions on a cadaver and have the cadaver be shocked. And guess what they found? They didn't die. Okay, they didn't die. If they were wearing gloves, they felt nothing. If they weren't wearing gloves, they felt a little tickle, but it was fine. Okay, so ideally you don't want to shock the person doing CPR, but if you do by accident, it's not a big deal. Okay, so you don't want any hands off the chest time that you can avoid. So absolutely minimize hands off the chest time, minimize interruptions. CPR is where it's at. But even the best CPR is not ideal. To get ideal CPR, you've got to be hard and fast. Okay, so remember Vinnie Jones. And the reason it needs to be hard and fast is that every time you stop, the coronary perfusion pressure drops off. So I know this is a bit of a complex slide, but if we can find it, which we can't. Anyhow, it doesn't matter. So the black line here is the perfusion and the blood pressure during chest compression. So at the start of compression, if we start in this one, start of compression, it's a bit on the low side. Okay, as your compression sort of carry on, it builds up and builds up. And hey presto, we stop here for ventilation. What happens to it? It drops right back down. And then you've got to build it back up again. Okay, now there are advantages to the 30-2, which we'll talk about later. It's still advocated that you practice 30-2. But if you imagine you're in the middle of your chest compressions and you stop for a couple of seconds because somebody wants to move you to put in an IV line, what happens to your pressure? It drops off and it takes you time to get it back up again. So the key thing is that you need to have good quality chest compressions with absolutely minimal interruptions in that. Because if you don't, you get an unhappy brain and an unhappy heart. So good quality chest compressions, you can't emphasize this enough. There is no point trying to tickle the patient. If you're doing chest compressions, you need to be doing them properly, hard and fast. Don't just do them for the sake of doing chest compressions to make it look like you are, because you'll achieve absolutely nothing. If you don't get quality resuscitation, you may as well not do resuscitation at all. You all know this. I'm speaking to the converted here, but that is the truth and the reality of it. Airways next. We all love intubating, don't we? It's great fun. We all get it in 100% of the time, except that we don't. Okay, it takes time and we don't always get it right. Is airway very important? Sure, it's important, but is an endotracheal tube important? Absolutely not. Endotracheal tubes have never been proven to increase survival from cardiac arrest. In fact, it's been proven that patients who get intubated do worse from cardiac arrest. Does that mean that endotracheal tubes are killing people? No, it probably doesn't. What it does mean is that when we intubate, we pause chest compressions. And we do know that chest compressions are what keeps people alive until we can fix the problem. So intubating is not necessarily a bad thing, but it is a bad thing if it interrupts the really important stuff that we're trying to do, which is keep circulation going. Okay, so other stuff that we can do in terms of airway, we can use supraglottic airways, which is the LMA or the iGel that we use here in this service. Much quicker to get in. Any idiot can do it, really. We teach firefighters in Ireland to put in iGels, and they can do it quite successfully. So it doesn't take a huge amount of training or medical experience, and it is pretty quick, and it's very, very effective. So breathing, do we need to ventilate the patient? Yes, we do need to ventilate the patient. We don't need to overventilate the patient, because if you overventilate them, you increase their intrathoracic pressure. What does that do? Well, it reduces the amount of venous return coming back to the heart. If you reduce the amount of venous return, then you have to obviously reduce the amount of cardiac output. So you want to have some ventilation, because ventilation will open up blood supply through the lungs, and it reduces strain basically on the right heart and allows blood to flow from the right side to the left side of the heart and allow blood to circulate. So you do need to ventilate, but you don't need to overventilate. This is also important in the post-arrest phase, because you don't want to overventilate and make somebody hypoxic, because that can lead to oxygen-free radical damage and further cell death at a time when a lot of cardiac cells are already dying. I put this slide up because I really want this t-shirt. Precordial thumps were sort of in vogue, if you like, maybe 20 years ago, went out of vogue because they didn't really work, and they're back in now. You can use it if you want, is the bottom line. So there's some evidence to say that if you don't have a defib immediately available and you know your patient's in VF or VT, then you can use a precordial thump and it might work. It might work, okay? So the situation where this would be an issue is that if you've got your patient, say, in the ambulance, you've got the monitoring leads on and they arrest, so you know that they're in a shockable rhythm, but you don't yet have your shock pads on, you can use a precordial thump. Now, I wouldn't delay getting my shock pads to do a donkey kick, but if you got two people, then it's certainly worth trying it. So defibrillator, what about the energy? What energy do you guys use now? 200, yeah. So it started out with, when biphasic machines came in first, it was 150. So it's been shown that 200 joules works a bit better. Single shock, so no longer stacks of 3, and ideally use it in the manual mode. Because if you use it in manual mode, you can charge the machine while you're doing chest compressions. That's the key thing. So again, minimize your interruptions to chest compressions. Charge during chest compressions, get the machine ready, and just pause for that 1 single second to press the shock button. As soon as you press the shock button, straight back in the chest, and keep doing chest compressions until your patient asks you to stop. Okay, even if you get a change in rhythm, it looks like a perfectly normal sinus rhythm, don't assume there's a pulse with it. Keep doing chest compressions until something changes. Happy enough? Drugs. Anyone disagree with that? So how do we give drugs? Well, IV obviously is a good choice. Intraosseous is probably quicker because you don't have to mess around with tourniquets and all sorts of stuff trying to get a vein up. And it's idiot-proof. You just find a bone, you drill into it, it's done. It's very, very quick. So the endotracheal route has been de-emphasized. You can give drugs downward, it doesn't really work. So you're better off just going straight for an IO if you can find a vein very, very quickly. So what do you put in there? This is one of our legendary scat paramedics who actually said this to me. A couple of weeks ago. Not alone would I take Wilco at his word, he is absolutely correct, but there's plenty of evidence to show that he is absolutely correct. So adrenaline does not increase proper functional survival from cardiac arrest. It's really good at getting ROSC back. Put enough adrenaline into an orange, you get a pulse. So it's good at getting ROSC back, and if that's one of your KPIs, then great, give loads of adrenaline. But in terms of what we're trying to actually achieve, which is good functional outcome from our patients, it makes no difference. Is it bad? Probably not. Is it bad if it interrupts your chest compressions and your defibrillation and your overall management? Then yes. So if you're interrupting your chest compressions to get IV access, to give a drug that doesn't work, that doesn't make much sense, does it? So you can give it if it's easy and you got all your stuff set up, but don't interrupt stuff to give adrenaline because it won't achieve anything. Similarly with amiodarone, it makes very little difference to the outcome from cardiac arrest, and atropine is no longer used, as you know, in the algorithms. So the bottom line is, the drugs don't work. We still use them. They work to make us feel better, but they don't really work in terms of getting functional outcome from our patients, which is really what we want to do. So that leads to the question, what is the value of ALS protocols? Would we be better off just doing BLS, just getting a load of St. John's volunteers to go out in our ambulances and just do BLS and not overthink things? I wouldn't agree with that, but what it's really important to do is, even though you've got your ALS protocols, is to not focus on the wrong things. So yes, you need an airway. Air needs to go in and out, but you don't absolutely need to intubate the patient at the very start of the arrest. You need to have an effective airway, but don't interrupt the important stuff to move the patient out of the way so you can get a tube in just to get a tube in. And make sure that the person doing chest compressions doesn't get worn out. You know, I know we're supposed to change every 2 minutes. If you've got a 2-person responding crew, that's not always very feasible or practical. Or if you're stuck in a very small bathroom or bedroom, again, it's not very feasible to be changing crew very often. But do bear in mind that the person doing chest compressions does get tired, and the quality compressions will go down because of that. So cooling, well, where are we at with cooling? Cooling does work when it's done in hospital post-cardiac arrest. The real question is, should we be doing it pre-hospital? And there have been a couple of trials about pre-hospital cooling of the cardiac arrest patient, and they haven't really proven it one way or the other. So there's no harm, but there's not a huge amount of benefit shown to pre-hospital cooling at the moment. But those trials have been small, and we think that there probably will be benefit in it, but at the moment there's not a huge amount of evidence to say that we really, really should and must be doing it. But we think it's a good thing. I'm sure you're all familiar with the concept of trauma centres since the 1970s. We brought our trauma patients, well, we haven't since the 1970s, but the Americans have, brought their trauma patients to a specialised centre because volume is good, isn't it? The more times you do something, the better you get at doing it. So high volume stuff makes you better at doing specialised care. And we know that with trauma. Should there be cardiac arrest centres? And that's a current controversy in cardiac arrest management. And what's the benefit of that? Well, a lot of people who survive the initial cardiac arrest die later from other stuff. So they die from cardiac failure, they die from brain failure, and they die from the cause of their cardiac arrest in the first place. So if we get ROSC in a patient and bring the patient to somewhere where they don't have access to the cath lab to treat that cardiac arrest, well, that may not be the standard of care that we should be aiming for. So the concept of cardiac arrest centres is somewhere that you can bring your patient who now has a pulse, or not necessarily with a pulse, that is potentially salvageable with good quality CPR. So you bring them to somewhere that has absolutely best possible care and the best chance of fixing the cause of the arrest in the first place. You're in the field, you've been working away for a while, when to stop? It's a difficult decision, isn't it? How do you decide when to stop resuscitation on your patient? I'm not sure if any of you are English soccer fans, but there's a guy called Fabrice Muamba who died, he did die, I guess, during a high-profile soccer match about 18 months ago. He had hypertrophic obstructive cardiomyopathy and arrested in the middle of the game. He was in arrest for 78 minutes and he got 15 shocks. He was a young, fit guy, so we're likely to go on a bit longer, aren't we? We're likely to think about carrying on a bit more than we would if he was an 88-year-old lady who is now in a systole. So there are lots of factors that will help you decide whether you should carry on or not. But if there's any doubt at all, do CPR. And up till now, we've been sort of thinking that, well, there's not much benefit to doing CPR in the back of a moving ambulance because CPR is only about a third as effective as a normal cardiac output. And if you do it in a moving vehicle, it's even less effective. So what's the point in moving them? So unless you've got a reversible cause like poisoning, drug overdose, hypoxia that you can't fix, then the thought has been that we'll just call it here. But if you've got a cardiac arrest centre with maybe more advanced things like ECMO, that you can use your CPR to bridge to ECMO, then it's worth transferring your patient even in cardiac arrest.
John, in that case, there was a cardiologist from London Chest
Yes.
on scene, and they did CPR and they took him to his hospital, the London Chest, across London. And there are lots of other factors that are exactly what you're talking about that are different to the standard sort of cardiac arrest type management, isn't it?
Yeah, there are lots of factors, but he went to essentially a cardiac arrest centre.
Cardiac arrest centre.
Yeah. If he'd gone to the local or the closest hospital that didn't have access to other stuff to fix his underlying problem, he probably wouldn't have had as good an outcome. And that's exactly the point, that we need to go to the most appropriate hospital for these patients. So an appropriate hospital for an 88-year-old in a systole may well be back into her bed, but an appropriate hospital for a young guy with salvageable pathology is probably a cardiac arrest centre. So it's just something that we need to think about as the service develops here. Other stuff that you can use to help you with those decisions would be using end-tidal CO2. So instead of using just a colorimetric change, which proves that you got the tube, well, kind of proves that you got your tube into the esophagus once, but it doesn't prove that the tube remains in the esophagus, we can use continuous capnography. So you can use both a waveform to prove that your tube is still in, and you can also use the number of the capnography to help you to see if your patient gets ROSC at some point. And also, we'll talk a bit more about this in the afternoon, but you can also use it to help you with your prognostication, and using echo to see if the heart is actually moving at all or if it's just in cardiac standstill will also help you with your decision-making process. So this is what we do. Is there a way of doing it better? Does anyone do it better? Well, as we heard earlier, Hennepin County probably does it a little bit better, and there are lots of other places as well. So Arizona use a cardiocerebral resuscitation protocol. It sounds very complicated. It's not. It's not just one thing or one toy or one device. It's a whole system setup. So they've got their dispatchers trained to recognize cardiac arrest or potential or impending cardiac arrest and dispatch the appropriate resources early. They've got their community trained in CPR. They've got lots of first responders. And they've got their EMS trained in a slightly different protocol. So they do some sort of slightly unusual things in that they don't ventilate. So they put in either a supraglottic airway or an oropharyngeal airway and just put on a non-rebreather mask at high flow. And they reckon that the amount of chest movement will move enough gas to get enough oxygen in and to get enough carbon dioxide out. They keep going on about doing 200 chest compressions after each shock, which sounds like, oh, 200 chest compressions, that's different. Well, if you do 2 minutes of chest compressions at 100 per minute, still 200 chest compressions. Okay, but their protocol talks about 200 chest compressions. But they've got a real focus in their EMS education on the quality of that chest compression during the cardiac arrest. And I suppose the key difference is that they don't ventilate for the first 3 cycles of their cardiac arrest. They seem to get good results, but it's not proven that this is the best way to go. One of the other places that does it a little bit, or certainly has improved how they do it, is Edinburgh. So some of you may have heard of the TopCat trials. TopCat 1 was where they measured pre-hospital temperatures in their post-cardiac arrest patients. So it's a fairly simple trial. They put out some research registrars to go out with the ambulance service, stick down a temperature probe and see what the temperature was in the post-arrest phase. What they noticed was that when they downloaded all the data from their defibrillators, was that there were a lot of pauses, that there was perhaps a lack of leadership on scene in maintaining the quality of the CPR throughout the whole phase of the arrest. So they felt that there was potential to improve what they were doing. And they also noticed an attitude from the pre-hospital care providers, which I certainly have noticed in Ireland, and I've had a tendency to have this myself. And those attitudes were, well, what's the point? They all die anyway. And if only 5 or 6% of your cardiac arrests are surviving, then they pretty much do all die anyway. So it's easy to understand why that attitude might be there. And the other thing that I've quite commonly heard is that, well, they got the tube, they got the drugs, we did our best, and you kind of shrug your shoulders and go, well, you know, not my fault. And it's not. We're doing our best. But can it be better? And the TopCat team felt that it could be better, and through a 3-pronged approach of education of their paramedics, of audit and feedback. So as well as educating them in the importance of good quality CPR, they actually downloaded their cardiac arrest data and showed it to the guys and went like, well, yeah, you got good quality CPR here, but then there's 90 seconds where the patient got no CPR. So what happened there? So when you actually see how that happens after an arrest, it's almost like videoing yourself in a scenario. You actually see how good or otherwise that you are. And the other thing they found is that if you've got somebody who can be there and be a cardiac arrest champion, as they call it, and provide leadership throughout the whole arrest, then things work a bit better. So how much better did they get? Well, pre-intervention, or post-intervention rather, their time to shock was quite a lot shorter. So they got the first shock in quicker, which we think is probably better. And that's just down to leadership, crew resource management, and managing the team better. So as pre-hospital care providers, we've got technical skills, which are easy to train for. You know, you can train how to intubate, you can train how to put in an IV line, you can do scenario after scenario, and practice how to put on a pelvic binder, etc., etc. And they're easy skills to acquire. The more difficult thing is the non-technical skills. So how you react to your situation, how your team reacts to your situation, how your team reacts to you, and how you react to your team. They're much more difficult things to train for and much more difficult things to control in the real environment. But they did find that by dealing with the technical and the non-technical skills, that the post-intervention stuff was better. So again, if you look at the hands-on chest time was much increased after this 3-pronged approach to their training. Again, apologies for the quality of this slide, but the amount of time that the patient had hands on his or her chest was dramatically increased post-intervention, post the TopCat trial. One of the things that's different between pre-hospital cardiac arrest and in-hospital cardiac arrest is the number of providers. So if you're in a hospital cardiac arrest, there's always student nurses, there's always wardsmen, there's always loads of people around that you can swap people in and out to do CPR and free up the other providers to get the airway, to get the IV access and so on. And what they found is that the no flow time, so the time where there wasn't CPR ongoing, was much greater if there were only 2 providers. Now, that's not exactly rocket science, is it? You could probably have predicted that. But again, that comes back to your dispatch criteria. So getting 2 crews there at the start when things are absolutely critical is a really good way of improving your outcome for your patient. And that's a whole system-wide approach, not just one particular crew. But I think the bottom line is that attitude reflects leadership, and all of these critical situations need leadership. There's got to be a clear leader and also clear followers. So, you don't need people to go in and go, okay, I'm going to get an IV line, and that becomes your sole focus and your sole task. What you need to have is a clear, as Cliff might say, a mental model of where you're going. You are responsible for providing quality resuscitation for this patient. That doesn't necessarily mean that you have an absolutely neatly tied down IV line. You need quality resuscitation from start to finish. So that's quality airway management, be it basic airway management or advanced airway management, and quality chest compressions. The correct drugs at the correct time are important, but not quite so important, and quality in terms of defibrillation for your patient at the correct times. Does it make a difference? Absolutely it does. So this again is outcome data from the TopCat 2 trial. So Lothian, the one in the red box, that's survival from cardiac arrest compared to other cardiac arrest regions in Scotland. So same Scottish Ambulance Service, same training for the paramedics, except the ones in the TopCat 2 trial got a little bit more training and a lot more training in crew resource management and the non-technical skills. It does work, but the bottom line remains compressions are important, hard and fast. Any questions, guys?
Thank you for that.